Assalamualaikum everyone.
Walaikum salam, ma'am.
आवाज आ रही?
Yes, ma'am.
So, can anybody tell me what we discussed yesterday? Anybody? What were we discussing yesterday?
मैम कल हमने कुछ एंटीमाइक्रोबियल ड्रग्स थे, उनके मैकेनिज्म ऑफ एक्शंस देखे थे। कुछ ड्रग्स होते हैं वो इनहिबिटर्स होते हैं प्रोटीन सिंथेसिस के, कुछ वो उनमें से कुछ ड्रग्स होते हैं जो कि 50s सब यूनिट पे एक्ट कर रहे होते हैं और कुछ होते हैं जो 30s सब यूनिट पे एक्ट करते हैं बैक्टीरियल सेल के। कुछ ऐसे ड्रग्स होते हैं जो कि न्यूक्लिक एसिड सिंथेसिस को इनहिबिट करवा रहे होते हैं, उनमें से कुछ ड्रग्स होते हैं जो कि प्रिकर्सर सिंथेसिस को इनहिबिट करवाते हैं, और कुछ ऐसे ड्रग्स होते हैं जो कि डीएनए सिंथेसिस को इनहिबिट करवाते हैं, और कुछ ऐसे होते हैं जो मैसेंजर आरएनए सिंथेसिस को इनहिबिट करवाते हैं।
Good, very good. So basically, in the past 2 days, we have studied the various mechanisms of antibiotic resistance. We have studied how the antibiotics are going to act, not antibiotic resistance. What is the mechanism of antibiotic action? We've studied in the past 2 days, or the past 2 lectures, we have studied how these antibiotics are going to kill the bacteria. And depending on the structure which it is going to target, it is going to be effective against the gram-positive or the gram-negative organism. Some antibiotics are going to be more effective against the gram-positive because they are targeting the peptidoglycan layer. Others are going to be more effective against the gram-negative because they have the ability to cross the lipid barrier and reach inside the cell. So basically, these drugs are going to have a lethal effect on the bacterial cell, and they're going to kill the bacteria. But then comes the time when the bacteria is going to try for its own survival. And that is the time when it will like to develop some mechanism by means of which it would prevent that drug from affecting itself. That is what we are
ਗੱਲਾਂ ਬੋਲਦਾ ਨਾ ਉਹ ਪੂਰਾ ਘੰਟੇ ਦਾ ਮਸਲਾ ਤਰਾਵੀ ਦਾ ਦੱਸਿਆ ਤੇ ਫਿਰ ਇਹਨੇ ਕਿਸੇ ਨੇ ਸਵਾਲ ਕੀਤਾ, ਫਿਰ ਉਹਨੇ ਮੋਤਾ ਵਾਲੀ ਇੱਕ ਲਾਈਨ ਦੱਸੀ। ਮੈਂ ਤਾਂ ਸੁਣਿਆ ਨਾ ਮੋਤਾ ਵਾਲੀ ਇੱਕ ਲਾਈਨ ਦੱਸੀ ਤੇ ਇਹਨੇ ਸਿਰਫ ਉਹਨੂੰ ਐਕਸਪਲੇਨ ਕੀਤਾ ਪੂਰੇ ਘੰਟੇ ਚ, ਉਹਨੇ ਜਿਹੜੇ ਦਲੀਲਾਂ ਦਿੱਤੀਆਂ ਨੂੰ ਤੇ ਇਜਮਾਈ ਉਮਤ ਤੇ ਫਿਰ ਹਦੀ ਭਾਬੀ ਕਿਉਂ ਪੜ੍ਹਦੇ ਨੇ, ਫਿਰ ਉਸ ਤੋਂ ਬਾਅਦ ਸ਼ੀਆ ਕਿਉਂ ਪੜ੍ਹਦੇ ਨੇ, ਬਸ ਇਜਮਾਈ ਉਮਤ ਬਸ ਬਰੇਲਵੀ ਤੇ 2 ਬੰਦੇ ਨੇ। ਉਹਨੇ ਕਿਹਾ ਕਿ ਤੇ ਉਹ ਜਿਹੜੀ ਨਵੀਂ ਵਾਲੀ ਹਦੀਸ ਹੈ ਉਹ ਸਹੀ ਹਦੀਸ ਹੈ। ਉਹ ਜਿਹੜੀ ਹਜ
अपना माइक जो है ना उसको म्यूट करो।
ਉਹ मैं उधर लेक्चर हज वाला सुनिया नहीं है, तो लेक्चर सुनने को आपको थोड़ी उस वक्त ही ना मैं हूं जरूरी भी हो।
So I was discussing with you the ability of the microbe to overcome what is going to have a detrimental effect on it. And basically, that is how it is going to overcome the effect of the antibiotic. And what are the mechanisms going to develop for the antibiotics to not be effective or not kill that bacteria? That takes us to today's lecture, and that is the antimicrobial resistance. And basically, antimicrobial resistance, as you can see from this picture, is the power which is giving to the bacteria against all these drugs. Basically, when we talk about antibiotic resistance, we see that it is a consequence of a selective pressure which the bacteria are going to undergo in different environments. And the two most common environments which we see are either in the hospital setting or in the community. In the hospital setting, as you already know, there are a lot of infections going on, a lot of bacteria. They are going to be exposed to a lot of antibiotics. Health personnel, their hands, they also come into contact with a lot of bacteria, transfer of these bacteria from one place to the other. all of this will contribute to the bacteria coming into an environment which is going to force it to change itself or to produce some adaptation by means of which it will be able to survive in that environment. In the community, what we are doing is that we are, for the benefit of our own food industry, we are giving drugs to the livestock. We are putting drugs into the aquatic environment so that the fish they can survive for longer time period. They do not get diseases. And once these drugs they become a part of the makeup of these animals or these fish, when we consume them, this drug is also consumed by us. And once in all these settings, these drugs are going to be coming into contact with the bacteria which are within the intestines of humans, whether it is the animals or the fish. These antibiotics, they are also going to come into contact with the flora which is normally present. And once it is going to come into contact with these flora, then they are going to destroy what is going to be sensitive, and some of them they will develop a mechanism by means of which they will be able to survive these selective pressures. So why is this important? Why is antimicrobial resistance important? Antimicrobial resistance is important because if a bacteria becomes resistant to a particular antibiotic, we then need to give a therapy which is maybe most costlier as compared to the one which we were giving before. It also means that we will have to give an antibiotic for probably a longer time period than was required. If the patient is critically ill, we may need to extend the hospital stay. All of these are going to result in increased cost, not only to the patient, but also to the healthcare system. And finally, in certain critical situations, when we come to a point where no antibiotic is working, it can even result in increased morbidity and mortality of those individuals. So we are very much concerned with the development of antibiotic resistance and how we can put a stop to this. This basically tells you the selection for resistance. How does this happen? Over here, we have lots of germs, and a few of them, as you can see, they are drug resistant. But when they are exposed to an antibiotic, this is going to kill all the sensitive bacteria, and this will only leave those bacteria which are resistant to that antibiotic, and therefore the good bacteria which are protecting us from the infection, like the flora which is present in our intestines, as well as the bacteria which is causing the infection, both of them would be killed, but only those are going to survive which have any mechanism by means of which it is resistant to that antibiotic. Later on, what happens is that the drug-resistant bacteria are now allowed to grow because now the field is open for them. There is no competition. Once they are going to grow, then they are going to not be effective against the same antibiotic which killed the susceptible bacteria. Now, if that infection occurs again, the antibiotic is not going to be effective. And this drug resistance can then be passed to other bacteria as well. And then in this way, it is going to spread from one individual to another. And it is also going to spread in the community. Yes, Aisha?
Ma'am, your voice isn't clear.
Okay. अब आ रही है बेटा?
जी ma'am, it's a lot better. Thank you.
Okay. So this is how the antibiotic resistance is going to happen. When the susceptible bacteria are going to be killed, the resistant bacteria will have an open field where they can take up the nutrition, they can multiply, and they can survive. And therefore, when they are going to multiply, the population is going to increase, and the resistance to that particular antibiotic is going to become more and more, and it will spread from one individual to another, from one community to another, and in the environment, it becomes very common. So what is antimicrobial resistance? Antimicrobial resistance or the antibiotic resistance is referred to when an antibiotic loses its ability to control or kill a previously susceptible bacteria. That means if an antibiotic is bacteriostatic or it is bactericidal, now it does not perform its function. And therefore, the bacteria is now going to survive in the presence of that antibiotic. Although the antibiotic was previously effective and it could either inhibit the growth of the bacteria or kill the bacteria. In other words, we are saying that the bacteria have become resistant to that particular antibiotic and they are going to multiply even when the therapeutic levels of that antibiotic are present in the body. So even in the presence of the concentration of an antibiotic, which would normally kill the bacteria, the antibiotic resistant bacteria will now be not killed in that environment. Clear? So this is how the antibiotic resistance has developed over the years. In 1943, penicillins were introduced, and over a couple of years, in the 1965, rather in say 1960, the first resistance to penicillin, that was the methicillin, that became visible. Then you can see tetracyclines, erythromycins, they were introduced in 1950s, and the resistance to these tetracyclines started developing in 1959. And in 1965, again, we had another penicillin-resistant strain of pneumococcus. So over the years, if you go through the timeline, you will see that newer antibiotics were being synthesized and a resistance of the bacteria to the older ones was becoming evident. And with the passage of time, we were losing the effectiveness of antibiotics and we had to build up new antibiotics or look for new versions of the antibiotics which we had previously. Now, mechanisms of antibiotic resistance could either be intrinsic or natural. That means the bacteria is born with a resistance to the drug, or they could acquire that resistance. What do I mean by intrinsic or natural? For example, when we are talking about an intrinsic or a natural resistance, we are talking about some inherent feature in the bacteria by means of which the nature has given it a resistance to a particular drug. And acquired is when they are undergoing certain changes in their bacterial morphology, or they are producing certain enzymes which they have over the exposure to the different types of antibiotics. Over the period of time, they have developed these changes, and these were not present when they were born or in the initial phases. And most of the time, whether it's an intrinsic or an acquired resistance, if it is resistant to one drug from a particular group, then it will be resistant to all the other drugs in that group. Natural or intrinsic resistance is very predictable because we know that this bacteria lacks the target for an antibiotic. Therefore, that antibiotic is not going to be effective against that. For example, we were talking about mycoplasma when we were studying the bacterial anatomy. And I told you that mycoplasma has a different cell wall as compared to the gram-positive bacteria normally seen. And this is because they lack the peptidoglycan. And since mycoplasma lack peptidoglycan, therefore they will not be susceptible to penicillin because penicillins, they act on the peptidoglycan layer. They cause the breakage of the peptidoglycan linkages, and therefore they are able to destroy the bacteria. Therefore, this is a natural attribute of the mycoplasma that it does not have a peptidoglycan. Therefore, it is not susceptible to the penicillin group of antibiotics. Then certain organisms, they have no mechanism to transport the drug into the cell. For example, majority of the gram-negative bacteria, they are impermeable to penicillins because these penicillins cannot pass through the outer membrane. And therefore, the penicillins are not effective against the gram-negative bacteria. So all these examples are examples of a natural resistance to a certain antibiotic which the bacteria have when they are born. Acquired resistance is when the bacteria does not have a resistance, but it develops that over a passage of time. This could be due to certain genetic factors or non-genetic factors. Non-genetic factors may be because of a result of a spontaneous mutation, which can occur because of a mutation in the chromosomes, which can be because of they have acquired a plasmid which has the genes for antibiotic resistance, or they have acquired a transposon which has the genes for the antibiotic resistance. And there are different mechanisms by means of which these genes are transferred. We'll discuss the genetic mechanisms in detail a few minutes later. Let's first talk about the non-genetic mechanisms. What are the non-genetic factors that promote resistance? First and foremost is if the bacteria is within a walled cavity. A walled cavity in case of an infection is known as an abscess. And if the bacteria is within an abscess, then it means that it is surrounded by a lot of WBCs, a lot of debris, a lot of pus. And within that abscess cavity, the drug will not be able to penetrate to a certain extent. It may go there in a very low concentration, but within the abscess, all the bacteria which are going to be present, they will not be effectively killed by the drug. So if the bacteria are walled off within an abscess cavity, they will not be susceptible to the particular antibiotic. For this purpose, the abscess needs to be cut open, and then the pus needs to be drained, the area needs to be cleaned, and then when the tissue is normal, in which there is a vascularization, only then to that area the concentration of the drug would be able to reach. Number two is the growth phase of the bacteria. As we know that penicillins, they act on the growing bacteria. So if they are in a resting stage, they will not be effective. The antibiotics are not going to act on the bacteria who are not building up the peptidoglycan there. So all these cell wall inhibitors like the penicillins and the cephalosporins, they are not going to be effective if the bacteria is in a resting stage. If it is not in the lag phase, the penicillins and the cephalosporins are not going to be effective. Also, there are certain bacteria like the Mycobacterium tuberculosis. They go into a dormant stage. They are within the body, but in the body, they are not within an abscess or in anything else, but they are within the tissues, and in the tissues, they go into a dormant phase. And in the dormant phase, what is meant is that they are not multiplying or replicating. If they are not replicating, then the antibiotic is not going to be effective. But they still have the capacity to start multiplying. And when they start multiplying, then if the antibiotic is given or if the antibiotic is being given, then these bacteria would be susceptible to that antibiotic. Then under certain conditions, the bacteria may convert itself into a protoplast. And when they form a protoplast, these organisms are these are those organisms which the penicillin has destroyed the cell wall, but it has not but it has not made it sensitive to the drug. In these protoplasts are those structures which have the cell wall removed by the action of the penicillin, but the damage does not go any further. Now, the bacteria is in the form of a cell which has a cytoplasmic membrane, but it does not have a cell wall. Since it does not have a cell wall, now it becomes insensitive to the inhibitors of cell wall synthesis, or those which are going to act on the peptidoglycan. If such organisms start synthesizing their cell walls, then they will again become susceptible to the drug. So, in a population of in a population of bacteria, if some of them develop into protoplasts, then they will become not susceptible, they will become resistant to that antibiotic. Foreign bodies such as surgical implants, catheters, and anything which has been introduced into the body through a wound like a splinter or a shrapnel, all of them, they are going to inhibit they are going to cause antibiotic resistance. Why? Because these will become a focus on which the bacteria can form a colony, protect themselves through their capsule or glycocalyx or biofilm formation, and the antibiotic concentration will not be able to reach them, and therefore they will not be killed. Then certain artifacts, like you are giving a wrong drug. For example, if an organism is not, if the drug is specifically for an organism in the urinary tract, and you are giving that drug for a respiratory tract infection, the concentration of that drug in the respiratory tract would not develop because the pharmacokinetics of the drug is that it is going to have an effect on the urinary tract, or it is going to concentrate in the urinary system. So if we are administering the wrong antibiotic, it will not have an effect on the infection. If we are giving it in the wrong dose, required is 500 milligram, but we are giving 250 milligram. If we are not keeping in mind the penetration of the drug. For example, if we are giving a drug which does not penetrate fully into the spinal cord, how do we expect that the meningitis is going to be cured? So these are certain clinical fallacies or clinical wrongs which we are doing when we are administering a drug and we are labeling it as the antibiotic resistance. If we start administering the proper drug in the proper dosage and with keeping in mind its penetration into the tissues, then this antibiotic resistance pattern would not be seen. Few antibiotic related factors which are contributing to the non-genetic resistance of antibiotic resistance development, and these are the inappropriate antibiotic usage, overusage of antibiotics, addition of antibiotics to the feed of livestock, and the failure to follow infection control practices. What do I mean by inappropriate antimicrobial use? A doctor prescribes you a medicine for 7 days, but an antibiotic is taken for 2 to 3 days. The patient starts feeling well, and therefore he is now no longer going to continue with the medicine. What it is going to do is that it will allow these bacteria which have survived in that environment to become adapted to that antibiotic concentration. And number two, when this antibiotic is going to be given the second time, then it will not be effective 100%. Number two, we are giving the antibiotics for viral infections. Antibiotics basically target bacteria. They do not target the viruses. For viruses, we have the antiviral infection. Commonly, it is seen that an individual has flu and he is taking an antibiotic for that without getting better. Basically, the reason being it's a viral infection and it has got nothing to do with a bacterial infection. Third is when we are not choosing the proper antibiotic. A proper antibiotic selection depends on the sensitivity of the organism to a proper antibiotic. For example, if a person has a throat infection, a culture from the throat needs to be taken, the bacteria grown, and the antibiotic against that bacteria tested. The ones which are sensitive, they need to be selected, and the appropriate antibiotic needs to be given. If we are going to give an antibiotic randomly, we are not sure which antibiotic is going to be effective against the bacteria which is causing the infection. And that is a very common way of introducing antimicrobial resistance. Then you have commonly seen that in a pharmacy, if you go and ask for an antibiotic, it can be given to you without any medical prescription. That is one way we are misusing the antibiotics. We have a sore throat, we go, we take the antibiotic from the counter, we eat it for 3 days, we feel a little bit better because either it was not a bacterial infection, it was a viral infection, it is already getting better, or even if it was a bacterial infection, it responded to the therapy, and then we come to the conclusion that this antibiotic is very good for us, and every time we are going to have an infection, we are going to go to the pharmacy and get the same antibiotic. And over the passage of time, it is going to become ineffective because we are putting the bacteria to the same environment again and again, and promoting it to develop some mechanism which is going to overcome that antibiotic concentration and allow the bacteria to survive. Then we are also using broad spectrum antibiotics when not indicated. For example, again, it comes back to the same factor that we do not know which organism is causing an infection. So if we do not know whether it is a gram-positive organism or a gram-negative organism, we try to give an antibiotic which covers both. If it was just a gram-positive organism, which could have been killed by a more by an antibiotic which was less, which had a less spectrum of activity, then it would be less liable to produce an antibiotic resistance. How do animal feed addition of antibiotics to animal feed lead to antibiotic resistance? Antibiotics are given to various animals to prevent their illnesses. Antibiotics which are present, they are going to kill the beta. Yes.
मैम तो जो कोविड पेशेंट होता है उसको हम एंटीबायोटिक्स क्यों दे रहे होते हैं?
बेटा कोविड के पेशेंट को हम एंटीबायोटिक्स इसलिए दे रहे होते हैं कि बिकॉज कोविड के पेशेंट में उसकी इम्यूनिटी बहुत लो हो जाती है एंड सिंस इट इज an infection which is affecting your lungs and it is connected with the throat, तो बहुत likely है कि उसकी कोई super added bacterial infection ना. So to avoid a super added bacterial infection, we are giving the individual antibiotic. क्योंकि हम सबके अंदर जो एंटीवायरल थेरेपी है वो शुरू में से नहीं शुरू करते, ठीक है ना. एंटीवायरल थेरेपी इज गिवन in a selected number of patients. Majority go, we start on the antibiotics so that they are going to prevent any bacterial infection from complicating the viral infection. ठीक?
Okay, ma'am.
Okay. When we are giving these antibiotics to the animals, they are going to go into their gut, and the normal flora which are going to be present over there, it is going to kill most of the bacteria. But the resistant bacteria, they are going to survive and they are going to multiply. And this resistant bacteria is then going to be present either in the meat, or it can be present on the produce. It can then be present on the surfaces when the meat is being cut, or it can go into the environment through the poop of these animals. So handling of these animals, taking care of these animals without maintaining the proper hygiene, without maintaining the proper practices, will not only contaminate the meat which is being produced, it can also contaminate the other things in the environment, and it will also result in contamination of the utensils. So in this way, it is going to spread this antibiotic resistant bacteria in the environment. So when an individual comes into contact with such contaminated food, it can either result in a mild illness or it can result in a severe illness. So the contamination can come from the food, it can come from the environment, but ultimately when we are going to eat this contaminated food, or we are going to not maintain our personal hygiene, we are using our hands, dirty hands, to put something into our mouth, we are also transferring these bacteria into our system. And once they are in our system, since they are resistant to antibiotics, they are going to cause an infection, which could be mild or it could be severe. So this is because of the inappropriate use of antibiotics in animal feeds. Any questions till this point? Okay, then we come to the genetic basis of resistance. There are three factors which are resulting in the genetic resistance in a bacteria. Number one are the chromosomal, number two are the plasmid mediated, and number three are the transposon mediated. Now, chromosomes, they undergo mutation in the gene that can either be targeting the drug, or it can target the transport system in the membrane that controls the uptake of the drug. So we have a gene on the chromosome which undergoes a mutation, and as a result of the mutation, the target of the drug becomes altered, or the transport system that gets altered. So then as a result of this, since the target is changed, the antibiotic cannot get attached to it. Since the transport system is changed, the antibiotic cannot pass through the membrane, and therefore it cannot reach its target site. The frequency of spontaneous mutations in chromosomes, they are very few, and they are much less as compared to those of the plasmids, and therefore they are less of a problem as compared to the resistance which develops as a result of plasmids or transposons. Clear? Now, what is the second mechanism of resistance? That is because of the plasmids. And plasmids, as we discussed in bacterial anatomy, they are extra chromosomal DNA materials which are present within a bacteria. And they are going to carry the genes for various factors, including the antibiotic resistance, and these are known as the R factors. And these genes which are present in the plasmids, they can become incorporated into the bacterial DNA. And when it is going to multiply and it is going to produce daughter cells, this bacterial resistance will then be passed on to the next generation and then to the next, so that a whole colony of bacteria will then be resistant to that particular antibiotic. Frequently, the plasmids, they are going to carry multiple resistance genes, and these multiple resistance genes can then be incorporated into the bacterial DNA. And therefore, the bacteria would not be resistant to one antibiotic, it may become resistant to a number of antibiotics. And these plasmids, they can also be transferred not only to this bacterial DNA, they can also be transferred to other bacterial DNAs as well. What these resistance factors code for, they code for the enzymes that can degrade the antibiotics or which can modify the transport system. Then third is the transposon mediated resistance. Transposons are again genetic material which are transferred either within the same DNA material from one place to the other, or they can also be transferred from one bacterial chromosome to another bacterial chromosome, or they can also be transferred to the plasmids. And drug resistant transposons which are present, they have 3 genes which are coding for number 1, the transposase enzyme, which is going to catalyze the excision and reintegration of the transposon. Number 2 is the repressor that regulates the synthesis of this enzyme. And number 3 is the drug resistance gene. So basically, this is a bacterial transposon in which you have these structural genes, and they are 3 in number. 1 which is going to code for the transposase enzyme. Number 2 which is going to control the secretion of the transposase enzyme. Number 3 which is going to be responsible for the resistance of the antibiotic. So here what is happening is that when the transposase enzyme is going to be allowed to be synthesized, it is going to excise this transposon from this bacterial DNA, and it will then become a free particle or a free structure within the cytoplasm or in the environment. Then it will be free to get integrated into another DNA. So this is one bacteria from where the transposon has been excised with the help of the transposase enzyme. It is carrying the genes for the resistance factors. Now it comes across another DNA of another bacteria, and over here this then gets integrated into the target DNA. And once it is integrated into the target DNA, the resistance factor genes will start making this bacteria resistant to that particular antibiotic. Is this clear?
मैम बेसिकली फिर हमें ट्रांसपोजॉन्स चाहिए होंगे रेजिस्टेंस के जो जीन्स हैं उनको एक्टिवेट करने के लिए
Transposons भी चाहिए होंगे resistance genes को activate करने के लिए, but this is one mechanism. The second mechanism which is very common, that is the presence of a plasmid. सबसे ज़्यादा common method जो ज़्यादा frequency में resistance को transfer करता है, that is the presence of a plasmid. ठीक है? That plasmid is going to be, and since the plasmid is normally occurring in a number of bacteria, so उसकी reason से उसकी with the help of a plasmid, most of the resistance genes are being transferred. What are the mechanisms of acquired resistance? How can this mutation or this transfer take place? We'll study this in detail later. Just to give you an idea, it could be through the process of transformation. जिसमें एक bacteria है, it breaks up its DNA, including into its bacterial cell breaks up, it releases DNA, and the DNA splits into smaller particles. And these smaller particles will be carrying different types of genes, and amongst them would be the antibiotic resistance gene. And this antibiotic resistant gene can then be taken up by another bacterial cell and it becomes a part of the DNA of that bacteria. And then this bacteria will become resistant to the antibiotic. And this is one way in which the bacteria transforms its resistance from one bacterial cell to another. Number two, it can do the same thing with the help of a bacteriophage. Bacteriophage is basically a virus which is going to infect the bacteria. In this case, the antibiotic resistance gene is taken up from the bacterial cell by a bacteriophage. Then this is released, goes into another cell, injects that resistance gene, and that becomes a part of the DNA of that cell. So this is the bacterial cell which was initially resistant. This was not, and after the transfer of the gene with the help of the bacteriophage, now it becomes resistant. And the third is that two bacterial cells, they can get attached through the villi. And once they are getting attached to the villi, then they can transmit the plasmid from one bacterial cell to the other. And when that occurs, then you have the spread of the bacterial resistance from one bacterial cell to the other. And in this way, it spreads much faster than the other two methods. Now, what are the four principal mechanisms of antibiotic resistance? How does the bacteria, through these genetic mechanisms, how does the bacteria affect the antibiotic resistance? Number one, it can block the entry of the antibiotic. Number two, it can inactivate the enzymes which are responsible for the activity of the antibiotic. Number three, it can alter the target molecule. Number four, it can cause the efflux of the antibiotics. So basically, these are the four methods by means of which the bacteria are going to make itself resistant to the antibiotics which are being given. How does it block the entry? It can either alter the membrane permeability. How does it do that? There are certain receptors on the cell surface which are going to get attached to the drug and cause make the membrane permeable to the entry of the drug. But if it changes this drug receptor, then this drug will not get attached to it. And if it does not get attached to it, the permeability will not be changed, and therefore the drug becomes impossible to reach into the interior of the cell. Number two, inactivating enzymes. We've already studied the beta-lactamase enzyme. This is going to destroy the beta-lactam ring, and when the beta-lactam ring is destroyed, then it is going to become inactive. And inactive, it is not going to affect the bacterial cell. Thirdly, we have the altered target molecule. For example, if a metabolic pathway is going from A to G, and then finally it results in the formation of a certain product, and we are acting or we are taking an antibiotic which is blocking the pathway between B and C, the mutation can result in an alteration of the pathway so that it will go, instead of going from B to C to D to E, it will automatically make a mutation which will go from B to E, overcoming this blockage and then finally resulting in the formation of the product. And therefore, in this way, it will then become resistant to that antibiotic. Finally, the drug, it is going to activate the drug pumps, as a result of which anything which even gets attached or goes into the microbial cell, that is then pumped out. Over here, there is no receptor change. The drug is getting attached to the receptor, it is going into the cell, but these drug pumps get activated and they are going to continuously pump the drug out, as a result of which a concentration within the cell will not be developed and the drug will not be effective against the particular bacteria. Any questions up till this point? All clear?
Yes.
Let's talk about a few multi-drug resistant bacteria. They are also commonly called the superbugs. These are those organisms which have become resistant to previously effective drugs. That is, they were sensitive to them, but now they have developed resistance, and they have developed not only resistance to a particular drug, but they have developed resistance to multiple drugs. And this is because they carry several resistant genes. For example, MRSA, it is methicillin-resistant Staphylococcus aureus. VRE, vancomycin-resistant enterococci. VISA, vancomycin intermediate or vancomycin-resistant Staphylococcus aureus. These are a few examples of the multi-drug resistant bacteria which have emerged because of all these various factors which we've discussed, but most of them are because of the genetic mutations which have taken place in these bacteria. MRSA is the most frequent nosocomial resistant pathogen. Nosocomial, can anybody tell me what is nosocomial? What is a nosocomial infection? Nosocomial generally refers to a hospital-acquired infection. In the hospital environment, as a lot of antibiotics are being given to the patient, there are a lot of bacteria as well. We have got a lot of surfaces being contaminated with the bacteria, as well as with, they can be exposure to the antibiotics as well on the surfaces as well. So because of these reasons, these pathogens, they are coming across a lot of antibiotics, and they are then liable to develop resistance through various mutations. MRSA has acquired a MECA gene, resistance through this gene. We won't go into the details of this. We just need to remember that it is a chromosomal mutation, as a result of which this chromosomal mutation occurred in the MECA gene, and this resulted in a formation of a penicillin binding protein, which is different from that which targets the penicillins. So consequently, it is resistant to all beta-lactam antibiotics. Now, penicillin binding protein structure has been changed, as a result of which the beta-lactam antibiotics cannot get attached to the penicillin binding protein, and consequently, they are not able to destroy the peptidoglycan layer, and therefore the antibiotic becomes resistant to the penicillins. Clear? Then we come to
मैम इस पॉइंट को दोबारा बता दें प्लीज.
MRSA जो है Staphylococcus aureus की एक species है which has developed resistance to penicillins and the cephalosporins. इसको हम methicillin resistant Staphylococcus aureus इसलिए कहते हैं कि because the first resistance was tested against the methicillin drug. But what we found out was that it is resistant to all the penicillins and all the cephalosporins. Why? Because it has developed a mutation in its chromosome in the MECA gene. And this chromosomal mutation has led to the formation of a new type of penicillin binding protein in the bacteria. It is no longer the same which was effectively controlled by the penicillins and the antibiotics. If you remember, हमने discuss ये किया था कि penicillin binding proteins का जो है, penicillins जो है, they go and get attached to the penicillin binding proteins. उसकी target site को वो block कर देती हैं, as a result of which the penicillin binding proteins cannot go and get attached to the peptidoglycan layer, and therefore the synthesis of the peptidoglycan layer is halted. यहाँ पे the bacteria have now developed a new peptidoglycan, a new penicillin binding protein. अब ये penicillin binding protein penicillins को cephalosporins के साथ attach नहीं होती. As a result of which the penicillin binding protein is free, and it is going to go and continue with the synthesis of the peptidoglycan. Therefore, the bacteria becomes resistant to the penicillins and the other beta-lactam antibiotics like the cephalosporins. Nosocomial setting यानी hospital setting में इसलिए ये most frequent है because penicillins and cephalosporins are very commonly given for infections in the hospital setting, और वहाँ पे most of the infections they are being treated initially with the penicillins and the cephalosporins. So उस environment में selective pressure जो हमने पढ़ा था, that is more, and that allows the mutations to take place. Clear?
Yes, ma'am. Thank you.
Penicillins and cephalosporins, this can cause the resistance by different mechanisms like for example, the production of the enzymes, beta lactamases, the penicillin and penicillinases and cephalosporinases. And as we discussed, this is going to inactivate the penicillin, the cephalosporins को inactive कर देगा, and therefore it will not be effective. Then there are certain extended spectrum beta lactamases. ये beta lactamases जो हैं, they are going to be produced by the gram-negative bacteria mostly, and mostly by the enteric bacteria, वो वाले bacteria जो हमारे gut में मौजूद हैं, हमारे intestines में मौजूद हैं. And they are called extended spectrum because they are going to affect the second and the third generation cephalosporins, as well as the penicillins and the first generation. So, in addition to the penicillins, first, second, and third generation cephalosporins are going to be inactivated by the extended spectrum beta lactamases. Then, as we discussed, the changes in the penicillin binding proteins. Here, the drug can be fully permeable into the through the cytoplasmic membrane. Then we can have the penicillinase coding plasmid in the bacteria, which is going to continuously produce the penicillinase enzyme. So all of these mechanisms, they are going to result in a resistance to penicillins and cephalosporins. Carbapenems, these are going to be degraded by the carbapenemases. Beta-lactam ring को degrade कर देंगे, the enzymes, they are going to develop again a resistance to the penicillins and cephalosporins. They are also produced by the gram-negative rods, and in most of these cases, they are occurring in the hospital environment, and they are resistant to almost all of the known antibiotics. Lastly, we discuss vancomycin. There is a whole list of drugs which are given in your book, and you need to go through the mechanism of each and every one of them and how resistance have been developed in the bacteria. I'm just giving you a few examples. Vancomycin, how did vancomycin resistance develop? There was a change in the peptide component of the peptidoglycan from D-alanine, which is the normal binding site of vancomycin, to D-alanine D-lactate. And to this, the drug does not. So here, the target site of binding of the vancomycin has been changed. And this is brought about by a transposon, which is on a plasmid. A transposon, it could be on the bacterial chromosome or it could be on the plasmid. So in this case, vancomycin resistance is carried by the transposon on the plasmid, and it develops a high level of resistance to vancomycin and cycloplanin, दोनों एक ही group of antibiotics. Now, we've talked about antimicrobial resistance, but how do we know that a bacteria is resistant to a particular antibiotic? For that, we carry out the antimicrobial susceptibility testing. We carry out the culture and the antimicrobial susceptibility testing. There are different methods. First of all, let's see what are the uses of this. It gives us the idea about whether the antibiotic is sensitive or not, whether we should give this antibiotic to the individual or not, which will aid the clinicians in their treatment. And this is also going to control the antibiotic usage, because then we will not be giving inappropriate antibiotics to the individuals. We will be giving only that antibiotic which will be effective against that particular bacteria. Now, different types of antibiotic sensitivity tests, some of them are diffusion based. Diffusion means that we are using a solid medium and the drug is diffusing through that medium to give us a result. Dilution means that we are preparing the dilution of the drug and we are adding the bacteria to it and seeing whether the bacteria are going to be killed off or not. And then we have a combination of the two. Just a brief idea about these. What we do is that this is a culture plate and this is the bacteria going on that medium. First of all, we prepare a inoculum. Inoculum is basically, this is saline, and we take up the colonies from this and we just make an emulsion over here. And we have to have a standard density of this so that we can standardize the whole test. Then what we are going to do is we are going to dip the throw a swab into that inoculum which we prepared, and we are going to spread it onto this plate. And once we have spread that, then we are going to apply these antibiotic tests. And once the whole procedure has been taken place, Then this is the plate, and these are the antibiotic, grounded antibiotic discs, which are containing the antibiotic concentration. And this we then put up into the incubator for 24 hours. When we look at the plate after 24 hours, what we see is this is the growth. Let's go to this. This is the growth which we prepared, and after 24 hours, the bacteria have grown on this culture medium. But we also put up these antibiotics. These antibiotics have a particular concentration of the drug in them. These are filter paper discs which have a particular concentration of the drug. This concentration, when it comes into contact with the media, is going to diffuse out from the disc and into the surrounding area. It will inhibit the growth of the bacteria if it is effective. So wherever you see this halo, that means that this drug is preventing the growth of the bacteria. Over here, the bacteria has grown right up to the margin of the drug, which means that this drug is not effective. This is not effective. This is effective. If we give this drug to the individual, there are very good chances of the infection or the bacteria being destroyed. Over here, if we give this drug, it is not going to be effective and the patient will not get well. So this gives us an idea. The antibiotic sensitivity is giving us an idea that these are the drugs which we can give safely to the patient and they are going to be effective in controlling the infection. But these are the drugs which are not going to be effective if we give and the patient will not get well. So this is known as the zone of inhibition. The area in which the bacteria does not grow, that is known as the zone of inhibition, and this is called sensitive and this is called resistant. This was the diffusion method where we utilized a agar plate for making this lawn and for testing the sensitivity of the antibiotic against a particular bacteria. The same thing can be done with a broth dilution method. In the broth dilution method, what we do is that we take 1 ml of the test bacteria and we take 1 ml of the broth, and then we add a concentration of the antibiotic as well. Antibiotic will be in different concentrations. Number 1 would be no antibiotic. Number 2 would be having 2 milligram per liter. Number 3 would be having 4 milligram per liter, and so on and so forth. The control 1 is without the antibiotic, control 2 is without the bacteria. So this would tell us that the test we are performing is going correctly. After incubation, overnight incubation, we are going to then look at these tubes. And if these tubes show any growth, then we will know that in this tube, for example, if it is showing a growth in this tube, it means that 1 milligram per liter is not the concentration which is going to kill the bacteria. Over here, you can see that we have growth in this, we have growth in this, we have growth in this, but this does not show any growth visibly. So visibly, we have a turbidity in all of these test tubes, but these are clear. So we assume that this concentration is the concentration which is either bacteriostatic or bactericidal. And from this, we are going to inoculate agar plate. From here, we are going to inoculate, and from here, we are going to inoculate. This shows us the presence of the bacteria. This means that in this concentration, it is bacteriostatic, but in a concentration of 32 milligram per ml, it is going to be bactericidal. So the drug concentration which needs to be given to the individual for controlling of that infection is going to be 32 milligram per ml. Clear? Is this concept clear? Most commonly, we are going to utilize normally we utilize the antibiotic sensitivity in this pattern for routine cases, for routine infections. But when we have critical patients where we need to know the exact concentration of an antibiotic to be given to control an infection, for example, in cardiac patients who have undergone cardiac surgery or such other conditions where it is very critical to know the concentration of the antibiotic which is going to be effective, then we carry out the dilution method, and in this way we are able to know which is the exact concentration of the antibiotic which is going to kill the bacteria. So minimum inhibitory concentration would be the lowest concentration of an antimicrobial agent that inhibits the growth of a microorganism, and minimum bactericidal concentration will be the lowest concentration that results in the killing of the bacteria. This is a method which is new. It's a new method, and it is utilizing both the diffusion as well as the dilution methods. As the dilution is basically why, because it is giving you the concentration. Over here, we have prepared these discs which have a concentration of the antibiotic in different gradients. So it is going to tell you whether the antibiotic is going to be sensitive in 32 milligrams or not. Instead of going through the whole dilution, this whole tedious process, we have now converted this into an e-test which has been applied on the agar plate. And when we place the strip, it will tell us whether the concentration of 32 was effective or 64 was effective. What are the advantages? And the third most important is the automated antimicrobial susceptibility testing method. I'm just giving you this so that you have an idea. We can use these machines also to carry out the antibiotic susceptibility testing. And the advantage is that it is easier and it's going to be reproducible as well. A few words about antimicrobial drug stewardship. As the antimicrobial discovery has been advancing, we have substantially reduced the morbidity and mortality. But with the widespread use of antibiotics, we also have come across the problem of antibiotic resistance, and especially the resistance of organisms to more than one antibiotic or one class of antibiotic. So then the need was to produce a program that would address these problems and that promotes the appropriate use of antimicrobials. It improves the patient outcome. It reduces microbial resistance and decreases the spread of infection, which is caused by multi-drug resistant organisms. So at present, antimicrobial drug stewardship programs are being launched all over the world, and in Pakistan also in different hospitals, this program is active. So it is going to basically reduce the inappropriate use of antibiotics. It is going to target the treatment with narrow spectrum antibiotics instead of broad spectrum, and it is therefore going to limit the adverse effects as well. The basic principles of the antimicrobial drug stewardship is this, and it will help us not only making a more effective diagnosis, but also it will help us in preventing a lot of complications which are associated with inappropriate use of antimicrobes. Any questions? Anything which you would like to ask? Thank you.